There have been so many heroes within the Asia 21 network this year. We thought it is only fitting that we hear from some of those who have been on the front lines of the pandemic in Asia and here in the US. To kick us off and moderate that conversation, we are delighted to have with us from the Asia 21 class of 2013, Tania Hyde from Australia, strategic advisor and former chief operating officer at Taylor Street Advisory. Joining her in the panel are Dr. Bryan Lim.
Hello.
Infectious disease specialist in Cebu, Philippines, Asia 21, class of 2011. Dr. Lungten Wangchuk, scientist and team lead for communicable diseases, World Health Organization, Nepal, class of 2013. Dr. Avinesh Bhar, Pulmonary and Sleep Medicine Physician, Sliiip, Asia 21, class of 2016. Tania, hard to believe that it's been 7 years now since we met at the Asia 21 Summit in Zhenjiang, China. Great to have you with us and always grateful for your leadership. Before we start the session, let's take a moment to re-energize with a mindful minute. Thank you.
Ladies and gentlemen, our 1-minute meditation begins. Sit comfortably. Straighten your back. Lower your eyelids. Breathe. Relax your eyebrows. Relax your facial muscles, shoulders, body, legs. Observe your own thoughts quietly. Thank you.
The COVID-19 crisis has, in a few months, redefined our work culture, entrenched us in new social norms, and put to test leadership. Clarity and focus in this world of insecurity are increasingly demanded of people and leaders.
Remaining anchored, connected, and mindful of our decision in such a rapidly changing world have a far more wide-reaching impact on creating together a sustainable society going forward.
So how do we come together to transform ourselves into mindful leaders?
And how do we re-engineer our inner mind for a better world?
Join us as we co-create a movement for mindful leadership in our summit workshop, held on the 8th of December, 10 p.m. EDT or 9th of December, Hong Kong time.
All are welcome and we will see you there.
Thank you, Sanjeev. I know that you've been working especially hard to bring us together across time zones. And obviously, it's a really great start to the session from Tom and Omar and our ambassador. I would also like to thank all of the Asia 21 alumni who have been working hard around the clock to save lives during this pandemic. I'm always humbled by the conversations I have with those within this network and the inspiration that I take from them into my everyday. I really would therefore like to thank Tom, Asia Society and Asia Society's partners for making this virtual summit possible so that the Asia 21 alumni can continue to share knowledge and collaborate with each other. And now also in quite an exciting way, we can share these insights with a much broader community. I'm really looking forward to this panel with our health experts. Sanjeev has already introduced our experts, Avi, Bryan and Lungten. So without further ado, I'd like to hand over to Lungten, who will set the scene for this discussion and share her experiences from on the ground in Nepal.
Thank you, Sanjeev. Thank you, Tania. I'm just going to start with a couple of slides talking about COVID-19, health systems and response. And I'm going to use Nepal as an experience example for sharing my experience as I work in Nepal. Can we have the slides up, please? Thank you. So next, please. Next. Okay. So as of today, there are more than 65 million confirmed cases and 1.5 million deaths globally. And the scale of the pandemic, as we know, is overstretching our fragile health system and finite resources and affected millions of lives and livelihoods. Like many other countries in Nepal, number of cases and deaths have been going up. We have recorded more than 240,000 cases and more than 1,500 deaths. Impending community transmission, which is driven by inward migration from neighboring countries, accelerator effect of mass gatherings and harsh winters of Himalayas leading to more time spent indoors and with poor ventilation. The accelerator effect that we have seen in Nepal is recently we have celebrated a series of mass festivals of this nation where mass gathering is one of the key drivers of the upward trend that we see currently. Nepal mounted a very robust and all-government, all-society response early on in the pandemic with support from partners, but the scale of pandemic is stretching our health systems and limited resources. Next, please. There are several good examples that worked in Nepal, such as strong political commitment from the highest level of the government and a real effort towards collaborative interministerial partner coordination in responding to COVID-19 pandemic at all levels. Nepal has recently been federalized. We have 3-4 levels of government which came together to respond to this unprecedented pandemic in the country. There are emergency operation centers that are established in all the provinces, which has scaled up management of information, communication, build capacity of the health workers at all levels of the government in responding to this pandemic. We also prioritize risk communication to inform, engage, empower community, which is very important in any pandemic, and it was critically very important in this pandemic to empower community to respond to the pandemic. And we also countered several misinformation, rumors and disinformation in the community, which was critical in this response. There is ramping up of quality assured laboratory capacities, which is unprecedented in this country, which is a very good example. Early on in the pandemic, we started with one laboratory to test COVID-19. And as of now, as I speak, there are 77 quality assured laboratory running COVID-19 tests. And of this, one of the greatest example is 40% of the laboratories are private and 60 public. So there is a good mix of public-private interventions or public-private collaboration in this COVID-19 response, particularly in testing and management of the cases. Next, please. Next slide, please. Also, we have rapidly escalated the surveillance. The previous slide. We have rapidly escalated the surveillance capabilities. Aggressive contact tracing coupled with risk stratified approach to testing was especially effective in the early stages of pandemic. Efforts are being made to strengthen the health sector response for imminent surge of cases that we will be experiencing and we are experiencing. Providing high quality and safe care, such as high standard of infection control, case management standard, capacity building of the health workers. Despite disruption in trade and travels, timely forecasting, procurement of the needed logistics for responding to pandemic and government and partners stepping up in resource allocation was a very good example, because this country has never ran short of commodities that are needed for COVID-19 response despite the trade and travel disruptions. Maintaining essential service, which is ignored or oversighted as we respond to COVID-19 pandemic globally is very, very important. And services for communicable, non-communicable disease and keeping up immunization services in Nepal. The immunization services has been exceeding its monthly immunization target for last many months despite the pandemic, and many innovative ways to keep other essential services alive with shift to service delivery models for TB, HIV, NTD, and mental health had been very exemplary despite responding to COVID. Many of the normal services did not suffer in Nepal as a result of continued focus on essential services. Next, please. So our best response to this and the future pandemic, we need to keep working on more effective strategies to target our communities with correct, timely, and easy to understand information and empower communities, which is often neglected as we think that this is a health response. But I believe that it has to be all government, all society response, including community empowerment, which is critical to the response to this pandemic. Our best response to health emergency, as we all know, is strong, robust, and resilient public health system with high quality health facility, adequately trained and motivated health workers, adequate supplies of medicines and diagnostics, high quality health data, adequate funds, which is critical for the health sector, and good systems for effective partnership, governance, and leadership. These are critical ingredients for this pandemic response as well as future pandemic response. We must continue to strengthen our health system, invest in health sector to better respond to this and future pandemic. The best example in the region I can quote is Thailand. Thailand has prioritized and invested for the last 4 decades in health sector, and this made the country stronger to combat this pandemic, and economic is picking up. This is the best and only way to protect lives and livelihoods in the face of pandemic and otherwise. Next, please. So what next? While we all eagerly wait for the arrival of safe and effective vaccine, it is still many months away before an adequate number of people are vaccinated to achieve herd immunity and control the pandemic. Till then, we need to continue to get back to basics. We need to get our basics right over the next several months. First is test, treat, and trace. I'm sure you must have, particularly those working on the ground, you must have heard this several times, that all suspected cases must be tested, treated in isolation, while their contacts must be traced and quarantined. There is no shortcut to controlling this pandemic if we don't do these 3 critical things. We must test. We need to build our testing capabilities and laboratory capacities so that we can provide free tests to all those who need the test. This will allow us to target our intervention to localized hotspot and avoid disastrous consequences of nationwide lockdowns that the world is experiencing, even as we speak in some of the countries. Get prepared for rapidly vaccinating the health workers, frontline workers, and most vulnerable population groups. Those are older age groups, those with comorbidities, as soon as approved vaccines or vaccines become available. We must strive to maintain essential health services, which is critical to ensure that second crisis on top of COVID crisis does not happen. The Lancet called it syndemic, or a double epidemic, a fast-moving pandemic over an emergency in slow motion, such as riding tide of NCD. The vulnerable population must have easy access to care for long-term chronic conditions and other diseases, so excess deaths that are not reported as COVID and visible does not happen. Next, please. Not only lives, but livelihoods, as we all know, need to be protected. This has not only been the gravest health crisis in a century, but also the gravest economic crisis. Government and societies must do everything they can to support their people during these difficult times. There are best examples in the regions such as Bhutan and other countries, which has done everything possible, not just the health response, but the societal response in ensuring that people do not suffer during this pandemic. But above all, and especially till we have safe and effective vaccine, our best buy is to get back to basics. Sometimes as we respond, we forget our basics. The bravery that this pandemic demands is wash our hands frequently, as simple as it may sound, but it's very, very difficult to adhere to avoid crowded space. We have all our rights, but we also have responsibilities not to infect others and save lives, to wear a mask, to keep our surroundings ventilated, and to be socially close but physically distant. And these interventions sound simple, but they're very difficult to adhere to. Pandemic fatigue, as we see, is setting in, particularly in the forefront with our health workers, with people who are responding, who had been responding to this pandemic from day one. It's been a year now, and I don't have to stress it further. I think most of you are in the forefront responding to this pandemic, be it individually or with the government or with the communities. But our success over the next several months will depend on how well we can adjust to this new normal. Thank you. Tania, over to you.
Thank you, Lungten, for sharing those insights. And also thank you to you, because, it's been undoubtedly a 12 hard, long months for you as you roll out those policies in Nepal. I'd now like to invite Bryan. Bryan, we heard from the keynotes, I'll just mention a couple of key words here: trust, preparedness, isolation, A-team, access, speed. From your perspective, and having Lungten set the scene, what are your insights from the Philippines and then more broadly?
Thank you so much, Asia Society, for inviting me. I miss all of you. I used to be based in Manila for 15 years, but 2 years ago, I came home to my hometown in Cebu, which is the second largest city in the Philippines, to care for my grandmother who had stage 4 pancreatic cancer back then. She passed away just last year. And as life would have it, it was meant to be that I'm here so I can help prepare my hometown for the pandemic. This is very personal to me. I've lost friends, colleagues, mentors, patients, and I lost my dad to COVID last June. And again, we have to continue working, and the best way to honor them is to save more lives and prevent new cases. My background in public health, infectious diseases, and policy and work experience in the private sector have propelled me to be in numerous fronts. I think the term here is there's no one else, because we're very few infectious disease specialists here in our province. And my main role here is really acting as a knowledge broker for several sectors. The Philippine healthcare system, I like the way that we pattern this panel, because I'll be speaking on behalf of my fellow developing countries. Our health system is highly devolved. The Department of Health acts as advisor and policy maker, but the implementation is under the jurisdiction of the local government leaders. And this is where the trouble steps in. Because here, the local governments are highly politicized and their policies are quite different. It's quite difficult to harmonize them. Hospital systems here are not integrated, majority of which are in the private sector. Health human resources, well, we continue to export our nurses and doctors. And our health information system here is still pencil and paper. So you can only imagine how this pandemic has put so much stress into our system. Largely, the greatest hurdle is communication here, because we don't have the benefit of a social consciousness of a past pandemic like Taiwan. Also, here in the Philippines, we don't have a mask-wearing culture. And personal space, forget it. Have you ridden our jeepneys? There's no such thing as personal space among Filipinos. How to be able to convince our leaders to work together and prioritize the unseen over the concrete problems of everyday life is a big challenge. And we also face a lot of pandemics in terms of pandemic of experts, so to speak, and a lot of pandemic of statements. Crazy, In Cebu, we had our first surge last June, and we became the epicenter in the Philippines then. And it was crazy. That was the time that at one time I had around 98 patients admitted, and it was crazy. I used to sleep in the car just to get by. And during that time, there was only 12 of us as experts here in Cebu. And the first cases that we had, just like to give you some stories so that you can have an idea of how it is. The first cases came from returning travelers from Manila. We had Chinese tourists, but we did not have any problems with them because the locals avoided them. No, but for some reason, our blind spot was on the returning travelers because it was a tough lesson to learn for everyone that the virus doesn't care what you look like, what race or nationality. Still at that time, it was manageable since the people here were, the first cases were from the rich families, no? And home quarantine was possible. However, when it crossed over to the lower economic strata, then we had the problem. We now had an outbreak. One of the first cases was a driver who got infected. He was sent home for home quarantine, but he lived in the slums. So this is where the social determinants come into play. How can you have home quarantine in the slum areas? And during that time, he had the drinking spree. And here in Cebu, we had the culture of tagay. As a sign of camaraderie, we used the same glass when we drink with our friends. And can you imagine, COVID was also shared. And we had an outbreak. During that time, all the testing had to be sent to Manila. Can you imagine? Our turnaround time is 7 to 14 days before the PCR results would come in. So imagine we would only do contact tracing after the results would come in after 14. It's too late already. And that was a time that local transmission became uncontrollable. So the solution there, the private sector came in. I agree with Lungten, no? And then we put resources to establish PCR labs. We partner with academics. And soon we are now able to test around 5,000 to 8,000 a day. And the hospitals there were not ready. Some hospitals limit or refuse to accept COVID-19 patients. It was a common sight for COVID patients to transfer from one hospital to the next, exposing so many along the way. So what we did there was we standardized infection control protocols, and we had to tailor fit the hospitals. We need to use the basements. We need to use the parking lots. We need to make do with what we have. And we had to train people how to use PPE, to don and to doff. When we did not have PPEs, I used to wear raincoats when I enter my patients' rooms because we ran out of PPEs. And also the Department of Health also provided financial incentives for those hospitals who would accept more patients. No? And one of our solutions is we established a triage system because clearly our hospitals cannot handle everything. So we converted all of the public schools into isolation areas for those who are mildly asymptomatic or the asymptomatic cases so that they won't be able to spread in their households, especially those who live in the slum areas. And the Jesuits converted their schools, and the Catholic Church donated their convention center, and we converted that into a COVID-19 facility for moderate cases. So we were able to reserve our hospitals and ICUs for the severe and critical. So I think that was a critical point in our response, and we were able to triage our patients accordingly. And back then, data was scattered, pen and paper. We were able to centralize that into emergency operations center. So all the ambulance, the police, even the crematoriums, and we established hotlines for teleconsultation. So that we were able to see the fruits of those initiatives, and our numbers began going down. And the PPE, the masks, we had to use all the mothers who had no jobs. So we used taffeta clothing, even plastic, or whatever clothing that are waterproof. We converted that into PPEs. And communication was a problem, really. So there was a point that someone leaked the names of the COVID-19 patients, and there were angry mobs who were going into their households, throwing stones at their homes. It was crazy, and people were now reluctant to be tested. So we need to use our creatives, our local artists, our campaign managers during the election stepped in, and they helped us have a more effective communication strategy. It really, truly was intense. So I started a show called Ask COVID Bryan, because the Filipinos love basketball so much. So it was a way that we can answer all those questions and misconceptions. Again, the shortage of contact tracing teams. Can you imagine during the start, we only had 5 contact tracing teams. Many quit, many got COVID, many were scared. But eventually we were able to increase our capacity, and now we have 180 teams. And we are able to contact trace 98% of the cases each time that there is a positive case. And we are quite proud of that. And health workers were getting sick. We even lost my mentor. One of my dear friends have died from COVID. And many also quit. No? And now people are leaving the country to go abroad. No? So we are now going to experience a massive human resource crisis soon. And the solution, we standardized the protocols, we modified the work schedules, we zoned the hospitals, we prioritized resources. And I'm glad that many volunteered and we appealed to their love for their hometown. And that was, I think, one of the major reasons why Cebu made it, because people came back to work because this is our home and we need to fight for our home. And the economic recovery, so the chambers of commerce united under one umbrella, wherein workplace standards were set. We created a checklist tailored fit for various industries. We trained the infection control officers in restaurants, in industries, as well as BPOs, so that we can minimize the risk. No? And at that time, we were now creating some form of trip advisor, an app where if you want to eat, you can look for areas where you can eat safely. So I guess I always say the solution to this pandemic is love, no? Love for ourselves, love for others. And if we practice that, then this pandemic can truly be overcome. Thank you, Tania.
Wow, Bryan, look, my heartfelt condolences to you, and thank you for all of the amazing work that you've done. It really has touched the heart. And with that, I'd like to ask Avi to speak a little bit about your experiences in the US. Bryan said how he is and representing some of the developing nations, and obviously Lungten has been there in Nepal. But obviously there are still challenges in what you'd so-called resource-rich countries. Avi, what are the lessons that you would like to share with this network?
Thank you, Tania. And wow, what a story, Bryan. I mean, I'm glad you were there at that moment in time, because Cebu needed you, and bless you and your family as well for all that you've gone through. And so over here, I'm based in the US. I'm, I guess, in a smaller town outside a metropolitan area, so somewhat less resource rich than certain parts of the US as well, but enough resources for us to be comfortable with. I think there was an element of unpreparedness due to a lot of lack of information. Sources that we thought initially should have stepped up. For example, the CDC left a vacuum, in my opinion, left a lot of areas for misinterpretation, miscommunication, a lot of, we have enough trouble already dissecting the science at a normal pace, let alone in a pandemic where people are just, it's kind of, if you think about it, the lessons of a startup, for example, you're trying to build a plane as you're falling. So you have so many things that you have to create. One thing is understanding of how the disease works, thinking about how treatment works, how to deliver that treatment, how to deliver information. So you have all these different facets here, and we found, I think, especially in the US, as much as I think the decentralized nature of healthcare in the US is a plus point. I think we saw a lot of the negatives as well, not having a national structure, not having a national backbone, I guess, of not even research driven infrastructure. I think, especially when you look at the outcomes for the steroid trials, for example, that came out of England. I mean, how they were able to put together a trial of a few thousand people and come up with conclusive evidence pretty quickly. And that was so much more beneficial than what we had tried to do over here, and not really didn't have any significant output till recently. So having at least a national infrastructure in terms of how to run research quickly, efficiently, with what you were doing basically on the ground, Bryan, which is to kind of come up with local rules of the game, just because every region is going to be a little bit different. And I think especially trying to tailor make that, and that's what the US does best as well, is to kind of tailor make some of the local policies and implementation, and using public-private partnerships at that level. But I think one thing that we've noticed over here is that the lack of at least a national infrastructure. And I think a lot of people are always worried about the encroachment of government into I guess, larger government into local government. But I think this pandemic has really, really shone the light on at least having a strong, if not agile, a national framework to run research, to then disseminate information, come up with basic protocols that can work in a small hospital and that can work in a very large hospital. And then each hospital having policies within that, just to kind of add on, is to kind of localize it. I think we were struggling with a lot of misinformation initially. Even we went through a lot of PPE issues. Nowhere as close as what you have. I think we're lucky where we are, where we could get access. But I think regulation as well then ended up being an issue. So you kind of have this a top-down model as well, where you have these certain rules that are put into place in peacetime that seem to make sense, that seem to protect the populace. But when it comes to a pandemic, when you have to react quickly, where you have to ramp up resources, where you have to shine light, or at least make sure logistically there's enough. And Lungten knows this better than I do. But when you have regulation that stops that from being developed, even for our testing initially, that was a huge issues in terms of who could test, whether the testing needed to be certified labs, uncertified labs. There was a lot of issues initially, but I think it's because of the infrastructure that we set into play, these rules that we set into play in peacetime, that doesn't take into account what happens in a pandemic. It gives us some caution about having a too heavy of a top-down approach as well. Well, it makes sense in peacetime to kind of have these rules so that, drugs and so on get tested appropriately, making sure the PPE, the quality of the PPE that comes in is adequate and tested to make sure that, N95 really supposed to do what it's supposed to do. All these rules and the stamps and certifications sometimes then add a roadblock when you need to ramp up supply quickly. So that's something we faced over here and finally got over the hurdle in the last few months. So it's fascinating, especially listening to Bryan's story and Lungten's story as well, is just listening the differences and experiences. But I think, we felt this lack of infrastructure, but the benefit as well has been the strong private-public partnership that has rolled out in terms of, labs and smaller testing labs coming up with more innovative equipment to use for testing as well. But again, if they did not know what their role was or how they could fit into that sort of, how they could fit in the pandemic, I think that made the rollout a little sluggish on our end. And we've seen here the number of cases that we've are dealing with and still dealing with as well now with the third spike that we're in. And, I think the issue with the winter coming in as well and more people being indoors is another huge challenge that we're going to face as well soon. But obviously nothing is compared as what Bryan and Lungten are going through, but we have our own challenges here. Thank you, Tania.
Thank you, Avi. Avi, one question for you, and then we'll move into some other questions. But I will invite everyone to please paste their questions into the hop-in chat as I ask these questions, and I can ask our panelists. And again, thank you, Avi, for all of the personal sacrifices that you've made as you've cared for people with COVID and to put systems and practices in place in your community. Avi, you mentioned that technology is a great leveler of care. What does that mean from your perspective? And I guess this will sort of move and pick up on the threads we had in the keynotes before about innovation and technologies broadly, and then access, which I'll then open it up to Bryan and Lungten to respond to.
I think there's always this pace of change that occurs, and then there's a mudslide that accelerates that change. And I think, this pandemic has definitely kind of opened the floodgates on at least telehealth or telemedicine from my personal experience. I think, again, it's fascinating that in the rural setting or the resource poor settings as well, that telehealth has been seen as such a core part of how to deliver care, because of a recognition that you cannot cover that larger populace with varying degrees of access, of resources, of understanding to be able to get access to care. And you can't deliver that in a way that you and I can safely go to sleep at night knowing that you delivered care that another human being deserves, if we're honest with each other. And so I think telehealth has kind of bridged that gap quite a bit. My practice was really based on that understanding that what I do as a physician really is to basically understand what is going wrong. And a lot of it is listening, and then local testing. And so delivering care can be done very much as good as in-person care for a lot of conditions. And I think that's what's accelerated during this pandemic. I'm hoping as well that we don't go back to a way that this pace of change, I think the pace of change needs to keep up. So one of the biggest impediments to change is actually the current people who have been practicing the way they have. And I find a lot of fellow physicians extremely resistant to a telehealth model because their whole livelihoods and their whole skill sets, comfort level has been built on the analog world. And so a lot of what I've found is it's not the patients that have a problem with telehealth, it's actually the physicians and the providers that don't want to change what they used to and what they grew up comfortable with. So the pandemic and how telehealth has been introduced and adopted and now demanded by patients or preferred by patients as well, it has been, I think, in my perspective, a silver lining, and forcing providers like us to change the way we do things. Because I think healthcare has been the most protected from the expectation of customer care or patient-centered care. I think we use patient-centered care sometimes as a great sort of feel-good motto, which we fail to deliver every time, because we all in healthcare sometimes have a sort of a pre-Copernican view of care. It's everything around the provider, the physician, his time, his thought process, his reputation. And so there's so much built into that. But I think a truly patient-centered approach really will have telehealth adopted, getting information to them to be able to make the decisions for them and their family as well. And because we're getting so much of this from WhatsApp and Facebook and even my mom and telling me what herbal concoctions I should be using, it's great that you have such local resources that people are interested, want to spread that information, but they do need some credible sources as well. And I think that's where technology can help to try to make sure that it's curated. But sometimes I use the word curated and it scares me because curated means someone deciding what's wrong and what's right. And we've seen as well in this pandemic, no one really has had the golden key to all things that are truthful, and we're all making stuff up as we go along. If we're honest with each other, even in terms of how we dissect science, whatever someone's breakthrough regimen this month is now dissected down and realized that the actual outcome wasn't all that great. But you have lay people who have to make these decisions based on newspaper articles and things that are clickbaits on social media. So I'm kind of giving you the technologies at level up, but then also as how this information goes out there.
Yeah,
exactly. So, yeah.
So, no, thank you, Avi. That it's really insightful. Lungten, I can see the others don't have the benefit of seeing you nod in Zoom. I'm seeing Lungten is nodding vigorously, as is Bryan. Can you perhaps let us know how technology, telehealth or others may play a role in developing nations as well? So, Lungten, if you could just respond to that, and then I'll ask Bryan too.
Tania, I think I agree with Avi that technology, I think, has played a greater role in this pandemic than other pandemic or emergencies as such, because this pandemic, close contact and coming together in one place is prohibited due to the nature of this pandemic. And in the developing world, particularly in Nepal, I think using IT has played a great role in capacity building, in communication, and you'll be surprised that some of the hard-to-reach communities where we would not have imagined there are internet services who could call on Zoom or Teams for training. So we have scaled up all our training sessions using the IT platform, and they have done not only wonderful services or capacity building just for this COVID, but all the essential services trainings are built on using IT. And you'll be surprised that in the remotest corners of Nepal, people could come online to get those training and communicate to the central level. Telehealth is working, in a big way that doctors from the remotest place could consult the COVID high-level centers through using this telecommunication media. And there are some experiences, even the hospital monitoring can be done from a central unit, because we cannot go and do face-to-face, a conversation with the patient because of the nature of the COVID. So I think IT, working in partnership with IT is critical, not only for this pandemic, but for future health system building. IT should be a critical component of health system building blocks.
Thank you, Lungten. Bryan, you mentioned, I think, pencil and paper, I think, in your opening remarks, and that was how data was being captured. Can you perhaps then speak about how far off you might be, but also, what opportunities are there still, even though there are some limitations at the moment?
Yeah, thank you, Tania. Yeah, I do resonate with Avi when he mentioned about taking patient-centered care more seriously. And ironically, it's actually technology that is interfacing that. No? For example, here in the Philippines, we do teleconsultation, especially for the elderly, and especially in our patients who are admitted, because a lot of them they really do feel isolated. Having COVID is such a lonely experience. Imagine if you're alone in the ICU, you cannot see your family, you cannot see your loved ones. And we have used IT and we have used Zoom also and the other platforms for them to communicate with their families. And well, it's not really a good thing about the pandemic, but in a sense, it has sort of hastened our acceptability of these technologies. And in many hospitals, they are now shifting to an IT platform that can capture all this data. And also, for example, there are some facilities that do not have doctors with them in infectious disease. So we place cameras so where we can communicate with them anytime. So also some low-tech innovations also. I never stopped going to clinic. So it's ever since the start of the pandemic. But I have shifted. My clinic is now under the mango tree. So we have a lot of mango trees here. And so I do clinic under the tree. And it's quite refreshing. It's well ventilated. It's safe. So it's going back to the basics. And I've also taken a lot of us have also taken the initiative to house visits. So because we cannot also deprive our patients, non-COVID patients, from care. So all this low-tech and high-tech, there's this wonderful intermarriage in a sense that we can make a patient-centered care more, more realized. Right?
Yeah, no, thank you, Bryan. Look, I think that's a really interesting thread, and it speaks to compassion and kindness, which came out in some of the questions again with the keynote. But I'm going to address a question from the audience, and that's around resilience and fatigue, particularly around those people working on the front lines. It's been a really intense year. I mean, Bryan, you spoke about sleeping in your car. Avi, I know you're working around the clock and it's, past midnight over there. How are you finding your resilience and fatigue, and what are you recommending to others in terms of keeping their energy levels going, or how to deal with essentially sustained crisis? Does anyone wish to tackle that? Avi, you have to unmute yourself.
Sorry, I think of it, sorry about that. I think of it as two sort of separate stresses. One is the physicality of it, which is the nights or the days and the lack of ability to kind of separate your own personal life from work because you're just always on call, basically. And that's a different level of exhaustion there. But then there's a second, or I guess another type of exhaustion, which is that emotional exhaustion of being powerless, because once these patients get sick, there's very little we can truly do to stop that slide, and there's a sense of helplessness, and that weighs heavily on our conscience. The protocols that we have in place to protect us and to protect the families and to protect the patients sometimes hurts the patients because they die alone, and it's not a good way to exit this world. I mean, it's a cold place to die in the ICU, where I frequently treat patients. So, there's this emotional toll that takes place. But I think beyond that emotional toll of being powerless is also the powerlessness of actually being able to control, or at least help other people understand what we're going through, because I think getting the word out about how bad this was in the hospital, to kind of get the information out there so people could understand, to kind of take all these precautions and not fall for pseudoscience and people claiming that this wasn't really as bad as it was. I think that sense of us not getting that information out was also weighing on us. People were debating this thing, politicizing issues when it shouldn't have been politicized, increased that frustration because we could see the carnage that was taking place in front of us in the hospitals. But there was this whole political debate about whether masks should be worn, whether this was a pandemic, whether this is going to have a second spike. All these sort of things that came about that just kind of frustrated everyone in healthcare, I think, at least from our perspective. So that resilience, I think, and then fatigue is actually twofold. One is that physicality, and the other one's the emotional toll.
Mm-hmm. Bryan, did you wish to address this question at all? And then it leads into the next question from our audience.
Yeah, I do empathize with Avi, and there was a point that I had 8 patients who came to the ER and all were dying, and there wasn't really much we can do. And to see young people die, and then there are people who would call you that your colleagues have died, and there was a point that my phone would just ring nonstop. People calling, what do I do? My mom can't breathe, and all those things. It can really take a toll on you. I haven't prayed this much in my life. And since the start, when we had our surge here, I just had to work and just keep on going. It was like I was observing a movie of some sort, and I had to detach myself to keep my sanity. And I think one way to sort of where I gain my strength from is the thought that really the pandemic can end. There is an end to all of this. There's an end to all of this. And the support from the colleagues from society and their text messages, the little things that they do really do matter a lot. And in the hospital, our mental health, well, thank God there's TikTok and all of those funny things on the internet, and you see all your colleagues doing crazy things. It's quite entertaining, And we in Cebu we have the word amping. Amping is a term that it means take care. It means it's a term of endearment. And one memory that I have that I could never forget is when we ran out of PPE and I was wearing raincoats and garbage bags. It was crazy, And the nurses were so meticulous. It was their intense focus to make sure there are no holes and there are no breaks. And all they say, Doc, please do not get sick. Please do not get sick. These little things, they mean a lot. And there is a hospital here that all the doctors got COVID, and we have around 100 plus patients admitted. The nurses stepped in. They said, Doc, train us. We can do more. We can do more. So every night I would teach them how to monitor. I would teach them what to look out for. And can you imagine people stepping up? So these things really kept me going. Yeah. And I think the sense of community, even despite all of the physical distancing that we have, there is a strong sense of belongingness, especially among healthcare workers. We are one family. And when I look at my colleagues with Avi and Lungten, and I feel connected to all of you, like you are my family also.
Wow, Bryan, it's again really emotional just listening to your response. I'm going to address just off that thread with Avi and Bryan just tackled. I'm just going to place the last question in to Lungten, but just about what's the role of different agencies? This is coming from the audience. What are the role of different agencies in ensuring there's the right information out there for people? So governments, NGOs, corporates. Do you have a view on, what that role is and how you might collaborate to get the right information out there? So, Lungten?
Thank you, Tania, and thank you, Avi and Bryan. I think they have touched base on what a correct information that could be understood by community and people should be disseminated, because it's also not the pandemic. I think it's the infodemic that we have to, counter a lot of misinformation, disinformation, and all sorts of information. And sometimes when the information is accurate, this is less likely to get out than when it is not. So it's information is very critical. What we have done in Nepal is all the partners have come together and we form a communication pillar where every partner plays, but the government takes the leadership. We have translated a lot of information in a very simple, locally understandable, language and information that is disseminated using various media. And we also know that the IT platforms that we have access to now helps us disseminate this. But what is important about information is spreading the credible information in timely manner and in a language that a community can understand. And we have seen these in practice. We are scaling up. Risk communication and information is one of the pillars we target for this pandemic. And in future, we must have a systemic way of, disseminating correct information. And if you see globally, many organizations such as WHO and UNICEF and others, NGO, they are trying to also combat not only COVID-19 pandemic, but infodemic. And it has been to a certain degree successful. As Bryan says, again, as we go deeper down to the community, the need for information is different than what we experience at a policy level. So connecting with the community and ground level, what is their need, and giving that information to the community is very important. Thank you. Over. Tanya.
Thank you. The last one really is around the vaccine and public health measures. Bryan, I guess I'll start out with this and then say, from your perspective, how do you think the vaccine will change things for you and over what time period? And but what other public health measures do you think countries should continue?
I think firstly, we need to sort of understand at this point that the vaccine is not the magic bullet to solve this pandemic. Even if we do, even if we already have the effective vaccines, the logistical processes that need to deliver all of these vaccines is a Herculean task. It's unprecedented. Even for developing countries, the delivery of vaccines, of existing vaccines, is already a problem in itself. No, not to consider all the anti-vaxxer sentiments out there as well. No? So I think it's very important that we, of course, it is a welcome addition to our defense against COVID, but we need to realize and to emphasize this to people that this is not the magic bullet, and we still need to continue all of our prevention measures. For example, there are a lot of problems with the vaccine. There's no way that we know whether the vaccines will work on you per se. So if you were vaccinated and you would cease to wear masks and face shields and all of preventive measures, you can still get COVID, right? And then you can even transmit that to others. So there's no guarantee. And also at the same time, in the way that we will target who will get vaccinated, again, there's a lot of things that need to be worked on. But what I'm trying to say here is we need to still continue all the preventive measures, even if the vaccine is here. That's my bottom line point.
Avi, do you have a view on the vaccine and and its perception within the US and how that will roll out?
Yeah, no, I think I don't think we've picked a winner yet when it comes to the vaccine, so we'll see. But I think the rollout of the vaccination as well should be run as a trial, sort of, with a lot of collection of data post implementation, just to make sure that if there's any sort of larger real world information that may skew or be different from under a trial environment, what some of these vaccinations have gone through. Just make sure the real world data matches to that. But I'm going to chime with what Bryan said. I think the biggest learning, not only from a treatment perspective, but I think even just what we've learned through the pandemic is that we thought this disease was somehow unique, special. But it's actually just reinforced my belief in the basics of medicine. There was nothing that, rocket science was not like the silver bullet. It hasn't been this magic vaccine. It's been the hand washing, the wearing your face mask, the social distancing, the thing that we know works well. And I think to make sure that we push that, continue to push that, because even if you, like you said, even if you have a vaccine, it shouldn't change how you behave as much. You shouldn't be walking up and still being in big crowds while this pandemic is going on. I mean, I'm not talking about 6 months, a year down the road once we have numbers that are a lot not in the pandemic class of numbers. And at that point, we can kind of, but I think we all have to still manage the basics of medicine and the basics of care. That should always be the foundation of what we do.
Mm-hmm. Thank you, Avi. Lungten, did you have a view on that from your perspective, sort of echoing Bryan and Avi's thoughts, or what does that mean from your perspective in Nepal?
So I totally agree with Bryan and Avi that a vaccine is not a magic bullet. For the next, let's say 2 to 3 years, we must continue to go back to basics as I presented earlier. But we must prepare, given the dynamic nature of the vaccine supply, given the dynamic nature of the epidemiology of COVID-19, it is a most welcome addition. Globally, I think COVID-19 vaccine as an accelerator, global, drive, it has done a great job, because for TB and HIV, we had been waiting for vaccine forever. And it is also possible that in a year's time, global solidarity can lead to several vaccine candidates coming up. There are a couple of candidates which are doing very good. We also have a huge target of 2 billion doses by 2021 as per ACT accelerator goals. I hope this will happen. But what countries need to know is vaccine is, first of all, not a magic bullet. Even if an efficient and effective vaccine comes, not all are going to get in a year or two. Therefore, strengthening and going back to basics is so important, and which is simple. As I said, it's very simple to say. I say it all the time to all the people here, but even for ourselves, imagine washing our hands 10 times a day. Everything is dry and, scaled up, especially winter doesn't help. But I think we must continue to, physically distant, socially close, like Bryan said, masking ourselves and the community, making sure we provide quality assured mask. It's not just that we have a protection and we have a false protection wearing a defective hands. The regulatory part on the logistics, including vaccines, should come in. Also for the vaccines, I think countries must start doing a couple of things. Having a vaccine strategic plan being planned, having your risk communication being planned, assess your cold chain, because we don't know what will be the cold chain requirement of this vaccine. It may be very tough even for a developing world to really have it out there when vaccine becomes available. We need to have human resource to deliver those vaccines. And we also need to capacitate our health workers who are in the forefront. Of course, I sit at a policy level, but I really admire Avi and Bryan and like hundreds and thousands and millions of them working around the world. We must protect them with all these available logistics, make sure that they're properly trained to launch the vaccine. Again, coming back to developing world, sometimes we always say, okay, developing world, maybe they have nothing more to offer because they don't have resource, but that is not the case. If you look at vaccine, there are a lot of success stories from the developing world, and we have a platform that is launched for, say, polio vaccination, immunization, systems that is already built in. So we can harness those what is already established even for the COVID-19, but countries must prepare now so that we are not taken by surprise like we were when the COVID-19 pandemic actually happened. So it is time for preparation. It is something like when we start locking down, we must do something. Now that we know we are anticipating some of the vaccine candidates, while we're responding to COVID-19 pandemic, I think we must prepare for vaccine introduction at a country level. Again, one thing I want to tell the countries is the misinformation. There are a lot of vaccine eagerness. There is also a lot of vaccine hesitancy. So risk communication, communicating right about this vaccine is very, very important, and country must do that. Thank you. Tania.
Thank you. Thank you, Lungten. I'm mindful of the time, and I guess the closing question really is, we're here together because of Asia 21, which, as Sanjeev sort of said, Sanjeev, I'd give you a big hug and everyone else right now if we could, and we weren't meeting virtually. Where are the opportunities for networks like Asia 21 to come together, to share these stories, and to really accelerate recovery or save lives? I mean, Avi, did you have a view on opportunities for Asia 21 itself, or who you might like to connect in with, or information you might like to share?
Yeah, no, I think what we were talking about earlier, and I think something that Lungten had brought up, was the public-private partnerships. I think we have such a array of and diverse people from WHO and on the ground, infectious diseases experts, and people like myself as well. And so you have such a diverse view of people. I think the idea is how do we disseminate information even within our organization, let alone outside, to say who are the people that need the resources and the help, and who are the management experts that can come in and help them with them, and just help them in terms of how to set up a pandemic response, and what are the information you need to get out there, how do you distill that, and people in the communications sector, how do you disseminate information? What's the best way to do that via social media? I mean, we're such a diverse. I mean, this where we take this from here can be huge. But I think it's a lot of the common problem that a lot of organizations face is how do you even harness within that and strengthen the communication within your organization so you can actually optimize a delivery of even care on the front lines. And so I think that's something that we should think about, especially in a pandemic when time matters and things have to be done extremely efficiently. And that's something to think about.
Thank you. Look, I think we're probably out of time now. Look, I wanted to say thank you again to all of our panelists for sharing their stories. Heartfelt thanks for putting your families and everything the things that you do, it's quite amazing. And Bryan, again, really your stories are extraordinarily touching. We now need to do our part, as Lungten said. We need to all be brave. We need to encourage our friends and networks to be brave and get back to the basics. I mean, if that's the easiest, quickest thing that we can all do, wash our hands, avoid crowded spaces, wear a mask, and to be socially close but distant so we can live in the new normal. I think that's something that we can all take from this conversation. So once again, thank you. And thank you to Sanjeev and Tom for allowing this conversation to happen, to which I will now hand back to Sanjeev to continue on with the next session. Thank you.
Thank you, Tania. Your mastery in moderating these important conversations and distilling key points is unmatched. And big thanks to Lungten, Avi, and Bryan for the heroic work you are doing on the front lines to keep us all safe. Please take care of yourself and stay in touch.